Pharmacists' Patient Care Process and Collaborative Practice Agreements. This fireside chat focused on the use of the pharmacist's patient care process and collaborative practice agreements and the experiences of states participating in an NACDD learning community. The panel discussion was moderated by Jeff Dirthaler, Population Health Consultant Pharmacist for CDC, and featured Ben Barrett, Manager, Pharmacy Primary Care Services at University of Utah Health, and Hannah Harold, Chronic Disease Prevention Program Manager with the Wyoming Department of Health.
Good afternoon, and welcome to the fifth Fireside Chat. So today we have quite an exciting presentation. We're going to be talking today about one of our strategies, which is team-based care, and our work with pharmacists. And in this work, we're trying to improve medication adherence and to achieve blood pressure control across our state populations. So you're really going to be pleased today to hear from our speakers. And today we have Ben Barrett, who's the manager of the Pharmacy Primary Care Services at the University of Utah Health. We have Ms. Hannah Harold, who's the Chronic Disease Prevention Program Manager with the Wyoming Department of Health. And we have our own Jeff Dirthaler from Population Health, who's a Population Health Consultant Pharmacist here at CDC. So I'm going to go ahead and turn it over to our speakers. I hope you enjoy these presentations. I'm sure you'll find them quite insightful. So, Jeff?
Great. Well, thank you very much, Letitia, and welcome, Hannah and Ben. We're certainly pleased to have you both here with us today. To set the stage really for the audience and let you know sort of how we got here, I'd like to take just a moment to kind of review the journey we've taken. And as Letitia mentioned, team-based care is viewed as being a very effective approach to improving outcomes. And when pharmacists are a part of the team, outcomes, especially high blood pressure control and diabetes, can improve. And so a lot of effort has been taken to engage pharmacy and the public health department at the state level to address some of the opportunities within the state to achieve control. To that end, the Division for Heart Disease and Stroke generated and released 3 key resources over the last year. Those resources included a resource guide on how state health departments can engage pharmacy. It included a resource guide on how pharmacists can unpack the pharmacist patient care process and use it to manage high blood pressure. And then it recently included a toolkit on the use of collaborative practice agreements. And so the intent trying to be to advance team-based care through the use of CPAs. Well, how we got here today is we wanted to go a little bit further than the traditional approach of disseminating those resources electronically with hot links to a website, followed up by perhaps a very brief overview of the content. Instead, we wanted to create a more engaging opportunity for select states to really try to use these resources within their state in partnership and really roll it out and try to develop a plan for action. And so we partnered with NACDD. We held a day-and-a-half workshop and invited 7 select states to join us. We then followed up with 3 webinars where those states shared their learnings with each other, discussed some of the challenges and barriers, and developed further refining their action plan. Now, please know that our goal of this initiative was fourfold. Initially, we wanted to try, overall, we want to try to increase the number of engagements between pharmacy at the state level and the state health department. We want to increase the use of the pharmacist patient care process for the management of high blood pressure. We want to increase the use of collaborative practice agreements between pharmacists and physicians, and we want to try to increase the number of sustainable pharmacy practice models. And so today we have 2 of the 7 speakers, 2 speakers from the 7 states that will talk with us about their journey. They'll share with us their goals, what they learned, and some of the challenges and barriers that they experience, and hopefully provide some insight to the other 47 or 43 states who also have access to those resources, with the intent of helping them leapfrog to the next level and accelerate the actual use and implementation of these resources. I'd be remiss not to extend a thank you to NACDD, Miriam, Susan, and Julia for their logistical support and coordination over the last 6 months. And also, we had 4 faculty members from across the country join us and serve as resources to those 7 participating states. They included Mary Alice Bennett, a professor from the Ohio State University School of Pharmacy, Lindsay Kunkel, the Director of Practice and Science Affairs with the American Pharmacists Association, Crystalline Weaver, who's the Vice President of Policy and Operations with the National Alliance of State Pharmacy Associations, and Troy Tregstead, who served as a pharmacy consultant, again, to the 7 states. We have today with us Ben from Utah and Hannah from Wyoming, but I'd also like to extend a thank you to the states of Arizona, Georgia, Iowa, Virginia, and West Virginia, who also participated in this project. While they're not able to be present with us due to time, we do have a report of their successes and feedback that will be available to all the participants as well. So let's begin with our conversation. And Ben, I'd like to ask you to start us off, and really as a way to level the playing field for everyone, if you could just give us a brief overview of what is the pharmacist patient care process.
Sure. So the pharmacist patient care process, I'll frequently refer to it PPCP as an acronym, is a tool that helps the pharmacist be able to establish a framework around the work that is already being done in the various different practice settings you'll find a pharmacist in. It was established by the Joint Commission of Pharmacy Practitioners in 2014, which is a conglomerate of various different pharmacy organizations. And it's rare that we get so much agreement, and so it was fun to have that here in this particular documentation that went out initially to describe what the pharmacist patient care process is. And in that, we learned that the pharmacist patient care process is composed of 5 different elements. The first one is going to be to be able to collect information, and then after you collect that information, assess it, make a determination on what needs to happen, and that would be then a plan. So with that plan, then we need to execute or implement the plan, and then ultimately, if we just left it there, that would be insufficient. We need to follow up by monitoring and making sure that whatever we planned worked, or if it didn't work, why didn't it work, and then be able to modify the plan. So that is the core, but that's all built around patient, a collaboration between the patient, the physician, the pharmacist, and the science behind the medications and the literature that supports the appropriate use of medication.
Great. Well, thank you for that overview. Now, I know your practice setting is at the University of Utah. Could you tell us a little bit about your practice setting, and how does the pharmacist patient care process, as you use it in practice, benefit public health? How does it improve the health of our nation?
So my practice at the University of Utah is embedded in clinics. So instead of being in a traditional dispensing role that you might think of most whenever you think of a pharmacist, I spend my time seeing patients individually to identify how to optimize whatever regimen they're on and make it work for them. So this is also my involvement there at University of Utah gets around to 15, 16 different practices, and it's primarily family medicine and internal medicine practices that we support. The second part of your question, or the second question you asked about how we use or how this process benefits public health, is really based off of the fact, well, a couple things in my mind. One is simply the number of touches that a pharmacy has. So typically, in this case, I'm talking about a community pharmacy, and being involved with a patient that is complex, has then a lot of risk associated with them. They are frequently at the pharmacy, and so taking advantage of that opportunity, those contact points, is part of it. But added really to that then is the process you're talking about here today, and that is an opportunity to use this process to help identify patients that maybe are not already engaged in the health system otherwise, but are coming to ask questions at the pharmacy or contacting the pharmacist. But also then is the follow-up. As you think through the process I described within the pharmacist patient care process, you'll note that there are various opportunities there to be ensuring that patients are on the right medications for their hypertension and that it's actually being successful in getting the effect we desire out of it. So we're seeing patients make actual changes or identifying patients that maybe are missed right now and needs to then be linked into the system.
Great, great. Hannah, could you start off with telling us a little bit about your role and as it relates to the 1305 grant?
Sure. So I am the Chronic Disease Prevention Program Manager for the state of Wyoming. And while it's titled Chronic Disease Prevention Program, it does not encompass all chronic diseases. We are essentially the 1305 program. So what I do is I manage our 1305 grant for Wyoming, and then myself and my small but mighty team of 2, we are the ones that implement the 1305 strategies and activities. And so as part of that 1305 process, this does include the pharmacist patient care process project and implementing that within our communities in Wyoming.
Great. So as you heard Ben talk about the pharmacist patient care process, and you think about the grant and the components of the grant, the things that stand out are self-management and monitoring, lifestyle modification, medication therapy management, and transitions of care. Did you see a logical connection and the potential value of coming together?
Yeah, so first of all, just looking at the team-based care aspect of this. Team-based care for a lot of public health, when they think about team-based care, the pharmacist hasn't always been the first thing that jumps to people's minds. You ask, who's in your care team for your patients? And I think very few prescribers or healthcare providers would say, oh, the pharmacist is a critical part of that team. So 1305, with its focus on team-based care as one of the focuses, certainly linked directly to this project. The other things you mentioned, so for example, home self-blood pressure monitoring or self-management of chronic disease. This project and pharmacist involvement with the pharmacist patient care process, providing this patient education, then helped enable patients, chronic disease patients, to better manage their own conditions. So there's a lot about 1305 and the goals of 1305 that tied in directly to this project.
Great, thank you. Now, as Ben mentioned, the pharmacist patient care process equally is the collaborative practice agreements, and a resource guide came out related to that. Can you just level set for everyone CPAs and what are they and how do they tie into team-based care and all of this?
Yeah, so a collaborative practice agreement, or a CPA, is a formal agreement, or in some cases a contract, really, between a prescriber and a pharmacist. And I say prescriber because it doesn't have to be a physician or an MD. It depends on the state there's regulations within each state, but it's an agreement between a prescriber and a pharmacist. And the CPA, the agreement, gives that pharmacist authority, or it delegates authority from the prescriber to the pharmacist to then carry out certain patient care functions for a specific patient or a set of patients. Now, the pharmacist already has the capability within their scope of practice to do certain things like provide patient education, to screen for disease, to administer immunizations, things like that. But a CPA expands that scope of practice. So the CPA gives the pharmacist the authority to then do certain other patient care management functions within limitations. So the prescriber, who is a part of that agreement, delegates under what conditions, maybe what drug classes, what diseases, what patients, et cetera, that pharmacist's scope of practice is expanded to. And so a CPA is a way to formalize this agreement. So like I said, it's an expansion of their current scope of practice and may include things that the pharmacist is already doing, but it formalizes that arrangement or that agreement between the prescriber and the pharmacist, and then also provides for a much more joint approach to care for that patient, or a team-based approach. You then have that pharmacist and that prescriber working together to improve that patient's outcome.
Great, thank you. So connect the dots for me. How does the use of CPAs and support team-based care and the work of the state health department?
Well, as I mentioned, it is a formal agreement that then defines that team approach to care between a prescriber, a patient, and the pharmacist. But team-based outcomes, as you mentioned, or team-based care does lead to improved outcomes, especially when looking at high blood pressure, which is what this project focused on. Patients that have a healthcare team coordinating their care and working together have better outcomes when it comes to their health. And especially when looking at high blood pressure and specifically having the pharmacist as a part of that care team, studies show and the evidence is there to show that your patient is going to have better outcomes. So in public health, when we're looking at all of these different factors within chronic disease patients and really any way you can help them improve that outcome, and when it's such a strong effect, such as team-based care that incorporates a pharmacist into that care team, it's a core piece of public health is that prevention and that education side.
Excellent. Well, thank you. Well, Ben, over the last 6 months or so, you've been involved in working with your state health department and your health system to disseminate and try to help, create a plan for using these resources and to achieve the team-based care. We'll give you a little bit of time to kind of walk us through your journey and tell us what you did, how it worked, what insight do you have for others?
So that journey began at a workshop here a few months ago. Doesn't seem like all that long ago, although there's been a lot of time passed between. And in our state, as I worked with our team on the public health side, we had a couple of things going on simultaneously. They already had a conference established where they had invitations out to various different members of the public health community, whether it was county Department of Health or some of the municipal public health departments. And that was already on the calendar for Teresa Rourke was the name of the person I was working with, and she said, "Hey Ben, would you want to come present and tell people throughout the state a little bit about what this is and what you can offer?" And I said, "Of course, that's an easy yes." So that was the very first step. She actually presented some material to the group there of quite a few departments of health, and she presented specifically information about PPCP, what it is, what a collaborative practice agreement is, much like you got to hear from Hannah. And then I talked to them a little bit about how I could see my vision for the way we could engage between pharmacy and public health, because I do see a lot of opportunity for both to benefit and ultimately for the patient to benefit when we work together between public health and pharmacy. And that was a very rewarding experience, got a lot of positive feedback and from those who attended. Simultaneously, I was also working on my side to try to ensure that within my system, so my goal was to first establish a mechanism to get all my staff familiar with what this process, what the PPCP is, how to use it in practice, and start to use it. And hoping that after that's happened, the next step would be then to further get our community pharmacies involved, those who are within our health system already. We share an EMR, and we collaborate on other things already. So that was a natural step. And then hoping to take those lessons learned between those two situations or those two settings into helping others throughout the state of Utah and help them understand how to integrate PPCP into their existing workflows. But part of that was then to get buy-in also administratively from various different decision makers within our system. So I had meetings set up where I was describing what the pharmacist patient care process is, what it means for change, going to medical directors and their meetings to be able to establish what expectations would need to be changed in order for them to help support the project. And then also my own staff meetings. So there was actually quite a bit. In fact, as far as staff meetings go and trying to get consistency with the use of PPCP, it is an ongoing process. it is not, unfortunately, something that simply, I did once, now it's done, check that off the box, right? Unfortunately, that would be simple, but reality is that it continues to be, attention is given to that in every one of our staff. We have monthly staff meetings, and so often we're asking questions about situations where we're using the pharmacist patient care process and how that resulted, so that we can try to be consistent with our outcomes too. That's another effort that we are that's taking quite a bit of time, is to ensure that as we're using a standardized process to get to the outcomes, then how do we measure those outcomes, and how do we end up consistently at the right outcomes that we desire? And so we've got a couple of things on the horizon. We just got support and had changes made within our electronic medical record where these things can be input directly into our system, so that we can start to aggregate numbers up to establish the value for what we're doing. Another step that is important for efficiency's sake within our system is to integrate now a standard documentation template that would help ensure that all pieces of the process are met, and to try to make the documentation side happen more quickly, and then hopefully to automate the aggregation of those numbers also through that process. That, unfortunately, is going to be months down the road trying to figure that out, but it is in the works. So that gives you some aspects of my side that I have done, and a couple things that are ongoing. Also from the Department of Health side, I've lost my contact with Teresa Rourke. She moved away from me, but I have another contact now there with John Reed is his name, and John's been very helpful as we now, well, they've gotten some surveys out to our pharmacists throughout the state of Utah to gather input on what they perceive their practice to be like already, and that then hopefully we can use that to assess any difference between what we want practice to look like compared to what it currently is, and use that to help facilitate the education for those pharmacists, give them the confidence and comfort level to be able to use this process in the existing practice.
Great. So how did you always have a relationship with the Department of Health, or did this initiate that, or how did that transpire?
No, Teresa reached out to me in regards to this project. I did have some contact with Department of Health through a couple of other projects, but not nearly to the extent that this project has really enabled us to develop a relationship. This project has formalized a lot between us, and been very valuable to me in that regard specifically, in an attempt to make sure that there is a good relationship between pharmacy and pharmacy practice and the Department of Health. So there's something of a relationship already, but this has been a step. In fact, since then, now a couple of other projects have stemmed from it, again, that are very helpful.
Right. Now, how was the pharmacist patient care process received within your organization, both from the pharmacists that are, that you're working with to evolve it, as well as support from administration? Any thoughts on that?
Yeah. The administrative side has been very supportive as long as I can articulate exactly what it is I'm looking for. Right? That is key. So that part has been easy as long as you can have a seat at the table. That's the hardest part, is getting to the right people when you need to. But once I've been there, they have been very supportive, partly because this is not intended to be work added. It's intended to just give some framework and rules of the game for the work that's already going on that helps us be consistent and end up with good, positive outcomes. So that's not a tough sell, but it can be tough then with people who are already in a routine practice and feel overwhelmed with the workload that I already have, and now you're adding me to be doing something else, or you're telling me that what I'm doing is not what I should be doing. And so depending on how I communicate that message about what the value of the patient care process is and its utility, it can come across in a way that people do hesitate to implement and don't want to push forward with the patient care process. And part of it's just habit, right? Change. For many of us, we want to change until change comes, and all of a sudden, oh, that wasn't so, I don't like that, and that is that is reality, and so I understand that. And when I get pushed back a little bit, I see that as a good opportunity for us to learn and then be able to help the next individuals I'm talking with to do better and avoid some of those problems.
So the Joint Commission of Pharmacy Practitioners came out with this unified support for this process back in 2014. How different is it from what pharmacists do today? Is it or do before that? Is there a significant difference, or is it a change in words and formalization? What is unique about this that creates that uncertainty about, am I doing something new or adding on, or is it really the same thing I've been doing?
My perception and my experience is that all of the elements we talk about in the patient care process exist in some way or another in the workflows that people are working through already. Mm-hmm. But because it has a different name or a different title, it's new, often it can be tough to want to engage if I'm already comfortable where I'm at. And so one of the points I'm trying to make as I talk with pharmacists is that really it's not that different, but one of the key components that it does for me is gives us consistent standards to be engaging with. So I use the term framework a lot, because all these things are happening, but are they happening in a very deliberate, methodical way that will get us to the same result every time, that same positive result that we're working toward? We all know that we can get there, but can we make it happen consistently? Yes, but we have to make sure that the input is consistent in the first place as well. And that's what I try to focus on is the fact that these exist. They're going. The assessment you're doing, even if it's simply at the point of dispensing at a pharmacy, you are already assessing therapy. You are already trying to make decisions about the best plan, potentially, not always to the same extent that we might be able to, depending on the setting. But there are elements that already occur in existing practice.
Yeah, it sounds like, I think we're all in agreement that it takes time for something new to catch on and become consistent throughout a large geographic area. It's been 3 years since it was released or endorsed by the 13 national organizations. Is it safe to say that in some places, if you bring it up, they're going to recognize the name and the process and understand it? In other areas, they may not. And if that's true, what advice would you give to the other 43 states as they, embark upon approaching either the health department or pharmacy organizations with this concept of utilizing the pharmacist patient care process?
The simple answer is yes, it is different. It is not uniformly being adopted so far, but I think there's a lot of momentum getting to the point where we are, for example, seeing it as a specific request within the schools and colleges of pharmacy. So part of curriculum now is a requirement that the pharmacist patient care process be taught. Now, one of the questions that will come up is, how do we teach it, or how do we make sure that that's happening consistently? And I would say one of the important elements is going to be that we be consistent with nomenclature. In the medical field, certainly within pharmacy, there's a lot of lingo thrown out, and sometimes I can use one term here and somebody else uses a different term, but we're all talking the same thing. Mm-hmm. And that certainly is the case potentially here. So one of the things I would suggest we need to be very deliberate about is using the same nomenclature, same definitions, being as true to the original intent as we can possibly be when we try to actually now apply it in practice. And in the process, then, I think we hope to end up at that more consistent result.
Sure. Great. So one of the goals of the project was to create awareness or to disseminate the project. Have you been successful in that throughout either your state or your health system?
Yeah. I think there's, as you asked the question, I think of so many ways to improve it beyond where it is now. But if I think back 6 months ago, yes, the fact that we were able to spread the word through departments of health in the meeting, the way that we were, the opportunities that I've had now to speak with pharmacy decision makers and medical decision makers and executive decision makers and staff within my system, I think the easy answer again is yes, it is gaining momentum, I know, for us, for me personally, but I also see it growing throughout the state with the help, especially with the help of public health departments who have a different network than what I've got on the pharmacy side and can help us be a voice.
Great. Excellent. Well, I'm going to come back and try to get a good feel for where you're headed next. But before we do that, Hannah, I'd like to bring you into the conversation and learn a little bit from you, your journey over the last 6 months. Tell us a little bit from the state health department perspective, how you went about it, what you achieved, what were some of the barriers, what insight you have for the other 43 states.
Great. Well, our journey was, I think, a little bit different than Ben's because, as you mentioned, you didn't really have much of a relationship with the Department of Health when this project started. For us in Wyoming, prior to this project, we had already been working with the University of Wyoming School of Pharmacy for a little bit under a year on a fairly similar project. We were working with them to bring pharmacists into the patient care team, which involved them recruiting pharmacies, training those pharmacists in the recruited locations on motivational interviewing, providing counseling, and working with patients on improving their chronic disease management practices. So when we saw this project come around, we knew that it would be an amazing way to build on the relationship we had already started. So to expand what we had going already, we sort of redesigned our approach. We realized, first of all, that what we were asking the pharmacists to do was the patient care process, the pharmacist patient care process. And it was an issue of nomenclature. Were we calling it that? Were we being consistent with our message? Our partner at the School of Pharmacy, one of the advantages we had in that partnership is our strong partner there, or our primary contact, is the dean of the school. And so working with the dean of the school then, when I brought up the fact that our students being taught this, and yes, the students were being taught it, as you mentioned, it's now required for the accreditation process, but was the message consistent? Were they learning that these are the 5 steps of the PPCP? Or did they just know that these 5 steps were important to helping patients improve their outcomes? So we've started to take a couple of different approaches. Within current pharmacists or current practicing pharmacists in Wyoming, we are still recruiting pharmacies into what the School of Pharmacy calls the Practice-Based Research Network. So their Practice-Based Research Network is a network of pharmacies or pharmacists who want to be involved in these different projects and studies on how we can improve pharmaceutical practice. So we've recruited pharmacies into the PBRN, the Practice-Based Research Network, to then participate in this project. As of right now, we have about 15 pharmacies recruited out of Wyoming's 60-something or so total pharmacies. So just under about 25% of all of our state pharmacies. And as part of this, each pharmacy that is recruited has gotten a welcome package. So last year, previous to this project, they received training, they watched PowerPoints, they met with our project coordinator at the School of Pharmacy, but it wasn't consistent. With these new resources that have been developed, we've now compiled them into this welcome packet. So when we recruit a pharmacist, or even in our recruiting process, before they're even a part of the project, we say, hey, here's these resources. We've had them printed and bound, teaches you all about the pharmacist patient care process for managing high blood pressure. We've included the community guide white paper on why team-based care that involves pharmacists is beneficial and how it's beneficial. We include information from the American Pharmacy Association on the pharmacist patient care process. They have their little book that they sell about the PPCP with details of every step and exercises that you can work through. So we've provided all of the pharmacists with these little packets of information. And that was the first stage in really making sure we were spreading a consistent message, is every pharmacy now has this book in front of them that mentions the PPCP hundreds of times. You know, this is the PPCP. One of the most helpful steps in finding pharmacies to recruit was speaking at the Wyoming Pharmacy Association annual convention. So shortly after our first workshop for this project, YPHA was holding, Y meaning WY, YPHA was holding their 100th annual convention. And so I had sent an email to the director and just said, hey, I'd like to present. I work in public health. I'm not a pharmacist, but I'd like to talk to pharmacists about how we can partner. And he's like, that's a great idea. Absolutely. We're 100% on board. And so I went to our annual Pharmacists Association convention and presented there a presentation that I titled The Role of the Pharmacist in Chronic Disease Management. So I was hoping to get the message across to them that there is ways that we on the state level side of public health would like to partner with pharmacists beyond medication dispensing and beyond the current scope of care or scope of practice that they have with patients. So at that presentation, I kind of gave a brief overview of the pharmacist patient care process. I skipped over it. They're all pharmacists. They've all been trained in pharmacy way more than I have. So they were all familiar with it, and I made sure to use the proper terminology of the PPCP. And then I went into some details and data on why pharmacists are uniquely positioned to play this important role in chronic disease management. So as you mentioned, Ben, someone with, I think the statistic is someone with 5 or more chronic diseases will see their provider or their prescriber about a dozen times a year, yet they will fill over 50 prescriptions in a year. So the pharmacist there for these patients that have multiple chronic diseases or chronic conditions, they have so many more interactions with this patient than a doctor or a nurse practitioner or another provider does. And so getting that message across to them to show them the numbers of just why they're so important in this process and should be a critical part of the team was extremely valuable. And then I went into the business side of things. So one of the biggest questions a lot of the pharmacists have had is, well, how do I make time for this in my practice? I'm so busy all day dispensing prescriptions. How do I actually find the time to sit down and do counseling beyond what I'm already doing and make these plans and assess, collect the info, assess, plan, and type up the info and share it with their prescriber? And so showing them the business side of things, which is the collaborative practice agreement. A collaborative practice agreement is really what makes this model sustainable in the current payment climate for pharmacists. So because pharmacists are paid based on medication dispensing for the most part, using a collaborative practice agreement and engaging in a formal agreement or formal relationship with a provider then gave pharmacists another way that they could potentially make this a profitable model for their pharmacy, or something that's even capable for them to do without losing profit at least. So that meeting was, I think, extremely critical in building these relationships and showing the pharmacists that on the public health side of things, we were there and wanted to make these partnerships and wanted to be a resource. Just letting them know that we knew they played a critical role in this chronic care management and our chronic disease management process, and that we were there to support them. And then I think, lastly, once we targeted the current practicing pharmacists through recruiting into the project and through this meeting and follow-up, providing them with assistance, we've been targeting those pharmacists in training currently at the school. So at the University of Wyoming, they have their first and second year students that are still on campus, and then their third and fourth year students who are in the residency, going throughout community pharmacies in Wyoming. and hospital pharmacies and other pharmacies. So working with the Dean of the School of Pharmacy, we've scheduled for me to go present pretty much that same presentation that I presented at the convention, but to each level of students there. So come this spring, when the P3 and the P4, the third and fourth year students are coming back for an intensive seminar there at the school for a couple of days, we'll be presenting to them. And then they go back out into the communities where they're in their rotations working with pharmacists, and maybe spread the message to those pharmacists that are already out in Wyoming. And then by presenting the same thing to the first and second year students who are in school, we're really getting that consistent message going throughout the school. So that's kind of been our overall approach, is targeting current pharmacies, targeting the students, and really trying to combine it all so that everyone's getting the same message.
Excellent. Well, thank you very much for sharing that. It sounded like one of the key success factors was making the connection between the health department and pharmacy. Did you already have those relationships established with the dean of the college, or was that new as a part of this?
Well, our relationship with the School of Pharmacy and the dean definitely grew through this partnership, or through this project. We kind of lucked out, because in our previous year of work with the School of Pharmacy, he wasn't the dean yet. And then he became the dean. So with his promotion, we gained a little bit more power there. We had someone in a good leadership position at the school. So we did get lucky with that aspect. But through this project and through my presentation at the convention, we did develop a good relationship with the Wyoming Pharmacy Association, and then with some important members on the Board of Pharmacy. The Board of Pharmacy in Wyoming is who every collaborative practice agreement, or they must approve every collaborative practice agreement that is written and entered into between a pharmacist and prescriber. And so by meeting the critical members of the Board of Pharmacy there at that meeting, they're able to then provide me feedback and provide me assistance when I am working on collaborative practice agreements with those pharmacies in our project. So going to that convention where a lot of the critical pharmacy stakeholders in Wyoming would be attending was a huge help for this project.
Great. Mm-hmm. What advice would you give to the other states who are not a part of this project to engage pharmacy? What lessons have you learned? What insight can you provide that would help them accelerate that?
Well, I think certainly targeting the School of Pharmacy. If you have a School of Pharmacy in your state, multiple schools of pharmacy, this is where the future of pharmacy is going to be for your state. And so by targeting our School of Pharmacy and the students there, we're able to kind of get a jump on those early pharmacists before they go out into practice in our state. And the School of Pharmacy, because they are required to teach the PPCP for that accreditation process, they're already familiar with it, and so they're a good partner to at least make sure you're sharing the same consistent message. And then the convention, or even just reaching out to your state pharmacy association, they were very helpful in giving me connections on what pharmacies were located, where they were located in Wyoming, who was a licensed pharmacist in Wyoming. And they're pharmacists, just like any other healthcare provider, they want good patient outcomes. They want their patients to be healthy. And so by showing them that they have the state support and the state Department of Health or Public Health Department support was critical in gaining their partnership as well.
Great. Ben, do you have any thoughts on what pharmacy, what approach they might take to engage individuals from the state health department?
For me, it's identification, right? I needed to know who to contact. Once you start to make some initial contact with somebody, then often, again, you get tapped into a network of a whole bunch of others, and that's very beneficial. So trying to identify that person, whether it's a county Department of Health, whether it's a state Department of Health, depending on where you're at in practice and what would be most applicable to your practice, I would encourage pharmacists to be looking for opportunities to collaborate with public health.
Great. Hannah, what do you think are some of the actions that your partners will be taking going forward as a result of your engagement?
Well, I think certainly as we move forward now with those pharmacies that we've recruited, the big process is actually going through our training with them. So the way we have it organized, one of the biggest barriers we see from our partners or from pharmacies that would like to be involved in this is money. I mean, money is always a barrier in most of the work that we're doing in public health. But how am I going to afford maybe the extra time it takes, even just for training, for learning what I should be doing, and collecting the data that we're requesting? And so using our 1305 funding, we are able to, through this project and our recruited pharmacies, reimburse them per patient that they involve in this project. And the first half of our project with them, we're just training on the PPCP, helping them actually implement this process, track patient outcomes, things like that. We train them on motivational interviewing, key parts of counseling, things like that. And once we reach the halfway mark, because grant funding doesn't last forever, unfortunately, once we reach the halfway mark of that project, that's when we bring into play the collaborative practice agreements. So then we start training on, now that they've developed these skills, which they may have been doing before, but now that they've really enhanced these skills and received formal training on them and have consistently been implementing the pharmacist patient care process for their patients, how can they make it sustainable once this project ends? So then teaching them about collaborative practice agreements, helping them identify certain prescribers in their area that they may be able to enter a CPA with, and walking with them through that process so that once this grant funding ends and this project ends, they then are able to and have the self-efficacy and the knowledge and the skills to actually move forward with a collaborative practice agreement and continue this model of practice.
Okay, great. Ben, any closing thoughts about where you're headed next? You've been through the dissemination the last 6 months. What's next for you?
Right now, at this point, it's now trying to get those results aggregated and looking at the actual metrics that will help now for me to go back to those same people I was talking to before and report back and say, this is what we can do with this process in mind. And then be able to take that information. Hopefully, in our state, we're looking to try to take that information to potential payers and be able to establish with them a relationship wherein we could work out that if you are willing to help us by giving the financial means to take care of these patients or to the end that we can, then we will be able to make the difference by whatever amount is showing in the metrics. So that's the hope right now, is to get good at the process and be able to share those lessons learned and use that value driven to establish more relationships with payers.
Great. Well, thank you. And thank you also, Hannah. We're going to move now to questions and answers from the audience. And the chat line has been open to where you can submit questions. We'd like to encourage you to use the chat box. And if you can, please include your name, your home state, and your organization. While we're allowing those questions to come in, I'd like to engage one of our faculty members with a question. And do we have Mary Alice Bennett on the line?
Yes, I'm here. Can you hear me?
Yes. Thank you, Mary Alice. Welcome. I'd like to just ask if you could share with us your thoughts on what are some of the challenges that the profession of pharmacy is facing as it relates to fully integrating the pharmacist patient care process into practice.
So I think Ben has really hit on many of what those challenges are. It's articulated them quite well. I think part of it is the terminology. It's not really something net new. It's a process that pharmacists have been trained on for years, but the terminology's changed. And some of this may be the sequencing or just seeing how it's incorporated into their day-to-day routine already. So in a way, calling it out. So it's the newness of terminology and seeing how it's incorporated and not seeing it as something that's layered on what they already do, but it's already integrated into what they do. So I think that's one of the challenges, getting pharmacists to perceive it as not all that new and also being something that they already do and is incorporated, can be easily or can be consistently incorporated into their day-to-day. I think another challenge is the perception by other healthcare providers of what pharmacists do. And so I think one of the things that the pharmacist patient care process does is market outside of pharmacy this role of the pharmacist as a manager of medications and a manager of the patient's disease states to help them get the optimal outcome from their medications. And so I think a challenge that the pharmacist patient care process may help us with is helping us articulate and communicate with other healthcare providers and the public what a pharmacist really does around maximizing, optimizing medication therapy and really helping patients to make the best use of their medications. And then, of course, there's always the payment mechanism. We are paid based on a product and looking for ways to build the business model that's sustainable around the patient care process.
Great, thank you very much. Mary Alice, we have a question from the audience. Cindy in Virginia comments that high blood pressure is definitely a worthy chronic condition, but would like to know what the plans are to expand into other chronic conditions. I'd like you to, if you could, respond to that. You're certainly one of the authors of the pharmacist patient care process, and would be interested in hearing your perspective on how this process applies beyond high blood pressure control.
And I think that's a great question, and I think one of the major messages we want to send around the pharmacist patient care process is that we don't want to just focus on the patient's hypertension. We don't want to focus just on the patient's diabetes. We want to look at the patient as a whole patient. And there may be issues that are not necessarily disease-related that are impacting how they are able to manage their day-to-day lives, their day-to-day expenses, just the way they are able to handle their disease state and their medication. So we'd like to think of the pharmacist patient care process as not being disease-specific, but looking at the whole patient and incorporating all aspects of the patient into helping them to live well with any chronic disease state.
Great, thank you very much. Next, I'd like to pull in another one of our faculty members, Lindsay Kunkel, the Director of Practice and Science Affairs at the American Pharmacists Association. She also authored the resource guide that is the method and resources for engaging pharmacy. And Lindsay, are you on the line with us?
Yes, I am. Hello.
Great, thank you and welcome. I was wondering if you might be able to comment on any additional steps or guidance that you can provide, to the 43 states that were not a part of this and didn't have the luxury of hearing all the details that the faculty provided. Is there anything that you can add that would help accelerate the engagement between public health and pharmacy?
Yeah, I think the biggest thing that public health and pharmacy can do is really just open the lines of communication. We heard today that the partnerships between the public health departments and the pharmacy organizations really solidified and grew through this program. And I think that's because they were forced to work together on something. I don't want to say forced, but they were working together on something that was really meaningful, where they were shared and common goals. And public health and pharmacy have a lot of those shared goals about improving patients' lives and population health. So there are many ways that they can work together, and that starts with opening a conversation, whether that's between the staffs of the State Pharmacy Association and the State Public Health Department, or convening other stakeholders, assessing the environment, through fielding surveys, and just finding ways to promote that team-based care and work together to expand the services that are offered within the state. And I think that just when public health and pharmacy thinks that they might have hit their stride together, there are new challenges that will emerge, and there's always more that can be done. Data sharing capabilities, understanding reimbursement opportunities. I think there are many ways that public health and pharmacy can align themselves and keep communicating about how to work together.
Great, well, thank you. Do we have any other questions from the audience? Anyone who's present have any questions? Okay, I'm going to move on to another one of our faculty members. Crystalline Weaver is the Vice President of Policy and Operations at the National Alliance of State Pharmacy Associations. Crystalline, do we have you on the line?
You do. Hi.
Hi. Thank you for being with us today, Crystalline. Now, Crystalline has been actively involved in developing the CPA toolkit and has done a lot of work in collaborative practice agreements. And I was wondering if you could share any thoughts you have around how to accelerate the use of CPAs across the states.
Sure, and I think I'll call out something that I think public health departments might be able to help with. As Lindsay mentioned, you know, having a impetus for public health departments and pharmacies to work together had these great outcomes that we're seeing now. The same is true for connections between pharmacists and physicians. You know, they're busy professionals that have lots of patients to see and lots of competing interests and you know, requirements that they have to complete. And so I think public health could play a role in building those connections. When you know of physicians who are interested in working collaboratively, and or even if they aren't interested because they don't know about the opportunity but would benefit from collaborating with a pharmacist, connecting them with pharmacists who have similar interests, and serving in sort of a matchmaking role as much as that can happen to connect those interested groups could really accelerate the growth of the use of collaborative practice agreements, which can be just so useful in expanding the scope of what pharmacists can do by allowing that physician delegation to occur.
Great. Can you bring some clarification to the relationship between CPAs and sustainable practice models? How are they related?
Yeah, so there are a couple limited cases, such as Montana, and recently a pilot program that was passed in Tennessee where collaborative practice agreements are tied into payment for services. And these are in both cases under Medicaid. But by and large, collaborative practice agreements aren't tied to payment from what we see across the country. There are ways for pharmacists and physicians to have formal arrangements with one another under like a business agreement or some other type of agreement that you don't want to call a CPA for physicians to bill on behalf of the pharmacist services when they're under the same roof and in some other specific circumstances. But I wouldn't want to call those collaborative practice agreements, quote unquote, because CPAs that allow for the delegation of patient care services have a lot of extra requirements that you'll have to comply with, such as getting them approved by the Board of Pharmacy or other requirements that are state specific. But those other less defined agreements that could allow for billing opportunities between pharmacists and physicians don't have all those extra requirements. So you don't want to call it a collaborative practice agreement necessarily, but maybe a business agreement or some other term that doesn't tie in that delegation role.
Great. Thank you very much for that clarification. We just have a couple minutes left, and I'd like to ask both Crystalline and Mary Alice to comment on what is your recommendation for how do we track progress with the use of implementing both the pharmacist patient care process and CPAs. Let's start with Mary Alice. Could you comment on how do we track progress with implementing the pharmacist patient care process?
So it is a process, and it's the outcome that we're obviously most interested in. And so I think we want to look at the uptake of the use of the terminology, and as we look at outcomes of patient care, when we're trying to compare one to the other, I think we want to be looking back and seeing if all the steps of the pharmacist patient care process have actually been implemented and followed, so that we see that consistency of care. So when we're comparing one practice to another or one outcome to another, that we know that that consistency piece was there. I think in the future, as we look down to quality measures, I think we'll be looking at how much is the pharmacist patient care process incorporated into EMR templates. Are we using a consistent process within our electronic communication systems? And I know that there is a pharmacist e-plan being developed and emerging out of North Carolina that I think will help us in that tracking as well. So I think it is as we report outcomes, looking back to see that the consistency of the process was used to get to those outcomes, so that those outcomes are meaningful to track comparing one to the other, and then looking at consistency across our electronic mechanisms for communicating as well.
Great, thank you very much. And quickly, if I could ask, Crystalline, do you have any thoughts on how to, what does success look like as it relates to the uptake of CPAs?
Sure. So similar to what Mary Alice said for the patient care process, it's a means to an end, not an end for sure. A collaborative practice agreement might not be necessary in all collaborative care delivery models, depending on the setting, the services that are being provided, and other things. It's just not always necessary for collaborating providers to delegate some type of authority. And so if there's no delegation happening, then there probably doesn't need to be a collaborative practice agreement. So measuring the number of collaborative practice agreements and things like that probably isn't useful, but looking at it from a cultural standpoint, do we recognize that collaborative practice agreements exist in payer systems to allow pharmacists prescribed products to be covered under a prescription benefit, or systems that collect and collate, pharmacist credentials and credentialing systems as that develops. As we get payment for services, are collaborative practice agreements recognized and incorporated into those type of arrangements? More on a system level, I think, is probably a better assessment than trying to count the number of CPAs that are in place.
Great, thank you very much. And that brings us to the end of the Fireside Chat. I'll just close with a couple of quick comments and then turn it over to NACDD for last words. I certainly want to thank NACDD, our states, again, Arizona, Georgia, West Virginia, Iowa, and Utah and Wyoming. All of their findings will be available and distributed through NACDD in the near future. I also wanted to remind participants that next week during the virtual roundtable, we have a little bit of a bonus in the sense that we will be rolling out the TRICARE medication adherence data, which was recently presented by Dr. Matt Ritchie here at the CDC. He will be available to answer questions related to that data during the roundtable next week. Again, thank Hannah, thank Ben for making the trip and participating. Really appreciate all your comments and findings. And then finally, I'll turn it over to NACDD for final wrap-up.
Great. Thanks, everybody. This is Julia Schneider from NACDD, and we want to thank you, Jeff, and the division for this amazing opportunity to work with the state teams and our esteemed faculty. There's a number of resources available to everyone in the handout section of the webinar, and they will also be posted to our website. We will also be posting the recording of the Fireside Chat to our website next week, and we will distribute that information through our off-the-cuff newsletter. You will also receive a link to an evaluation tomorrow, and we ask that you please provide feedback for today's event. And as Jeff mentioned, there will be a virtual roundtable next week to continue the discussion in a more informal manner. So with that, we will close out the Fireside Chat. Thank you.